The Q&A panel is where we truly fire up the solution room and begin to address the problems of getting evidence into practice. This morning we heard different aspects about evidence implementation from experts in the field across core domains, and you caught that this morning, right? These are critical domains in the health service. We've looked at and heard about from clinical leadership, from policy and the nexus between policy and administration and research, and from Brian, a very compelling talk about the human side of the healthcare service and system. So now we're going to also be joined not only by Dr. Kylie Porritt, who's a core member, senior member of staff of JBI, but also by some of our colleagues from overseas. I'd first like to welcome, I think they're going to appear on screen behind me any minute now. So we're first joined by Dr. Kate Kynock, a registered nurse with 20 years of critical care nursing background, significant experience in evidence-based healthcare. She is the statewide knowledge translation manager for Mater Health and the director of the Queensland Centre for Evidence-Based Nursing and Midwifery, a JBI Centre of Excellence. Pleasure to have you with us, Kate.
Thanks, Greg.
Almost as famous, but more beardly for sure, is Adam Cooper, who's the, sorry, I should stay on script, shouldn't I? He's the Director of Nursing Continuous Improvement and the Director of the Affiliate Nursing Quality at the University of California, San Francisco. Just give us a wave, Adam, so we know you're awake. Yep. So Adam is also the director of the UCSF Centre for Evidence Synthesis and Implementation, a JBI Centre of Excellence. His clinical care background was adult critical care with many years of experience in evidence-based practice. And we are privileged to have him join with us. You would say this is not a user-friendly time for someone in California to join an event in Adelaide. So with that warm welcome to you, it's now over to talking through and answering some of these questions. I'm just going to get into a comfy chair. We're all, you can hear us? Okay. Yeah. So when you registered for this event, you were asked two questions. The first question was, do you have a question about implementation? And the second question that everybody was asked was, what about barriers and challenges that you've come across? What are some of those? So we're going to start with a question that came from that registration process. I'm going to ask for your views and opinions about that. And then after that first question, I want to open it to you, who are here today, to see if you have any additional questions you'd like to ask. And we'll just go with the flow, however that happens to turn out. So the first question is really rather broad. What are strategies to implement evidence-based healthcare? This is actually from the Director of Research at a university in the country of Chile, who's part of the live stream, I believe, today. But he's asking, what are strategies to facilitate implementing evidence-based healthcare? I think it's a very broad question, and I wonder if we can just change it a little bit, because it crosses clinical domains, it crosses policy, research, and consumers. So I wonder if it might be easier for us to grasp a question like, what low-hanging fruit would help accelerate implementation of change in clinical practice? Kylie, I want to start by asking you.
Okay. Well, I think probably the simple answer is there's probably not one particular strategy that will help with that. So I think it's whatever implementation strategy you use, it's going to have to be sort of multi-component. And I think it's very similar to the things that we've been listening to today. It's about getting people engaged. So I think at the very beginning you have to have buy-in from everybody to want to be able to want to change practice. You have to be able to have leadership to lead them through that change practice. and I guess the support as well, there needs to be that supportive network to be able to sustain that change practice as well. So,
Carolyn, you've had some remarkable experience of engagement.
Definitely around policy. I mean, I suppose what I would say for evidence-based policy change is that one of the things that we try to do is meet policymakers where they live. So, and they live in a world of political constraints, public discussion around any decisions that are made, ministers with lesser and greater appetites for change. So one of the things we try to do is consistently build relationships and trust, and consistently sort of present bodies of evidence, but also help them access evidence quickly when they need it and help them find the low-hanging fruit. So sometimes we talk about big aspirational end goals, but then also work with policymakers where they are in the small opportunities where they can see and bring about change without, just working with them in the practical space of political and financial constraints. Yeah.
So have the big picture view, but don't forget the immediate landscape.
Yeah, be a trusted advisor that isn't going to. I think policymakers are often very wary of political consequences of actions, and I think working in a way that is sensitive to that and timely and responsive, I guess, is how we've.
Terrific. You know, I'm coming to Brian. Do you want to input on low-hanging fruit?
Speaking up that point, is you meet people where they are and bring them towards you. But you need to understand what is the space they are living in right now. But you can't just keep throwing facts at them. It's like saying, if I shout louder, they'll learn English. You know, it's not exactly a well-known strategy of effective communication. Yeah. So you have to know where they're at and connect emotionally and build trust. So all strategies tend to be so dry they're almost desiccated, which means that we end up using language that doesn't exactly clarify, it obfuscates, and people get lost. You know, the first time, it was almost like appendicitis, and there were two people, really amazing, really outstanding nurse academics, and it was one of the very, very first times I'd ever been to one of these, and it was back when God was still a boy, so it was a long time ago. And they talked about qualitative and quantitative research, and I was thinking, oh my God, I've no idea what they're talking about. You know, I just didn't know. And that's the challenge we face in terms of the strategy, is the language around the strategy needs to be clear, it needs to be plain language. I'm really proud to be a nurse, but every time I'd have a patient at triage, I'd say, what's the story? Because people present with a story. Our job is to interpret its meaning for them and a meaning for us. So a strategy, I think the low-hanging fruit is understand what the story is that you want to tell. Yeah. What is the story that people are telling themselves, and how can you bring those two narratives together?
Yeah, thank you. Now, Kate and Adam, for those of you that are in the room that might not know them, both have really extensive experience at coordinating and facilitating implementation. So, Kate, the question was, what low-hanging fruit would help accelerate the implementation of change in clinical practice? Do you want to chip in?
Yeah, thanks, Craig. I guess for us, where there is inconsistencies in care is the low-hanging fruit for us. So where there's data to show that there's that inconsistency, and also a big driver for us for change in, you know, the local healthcare context, as well as about patient experience. So, where there's negative patient experience, that's really an area where we're able to get leadership's attention and be able to use that, to leverage off that, and to say we need to look at the evidence and what we can implement here, and anything that has a financial incentive as well. So where we're going to be able to show that there's a cost benefit to the organisation, again, that's when we're going to get a lot of buy-in at all levels of the organisation in terms of change. So that's some of our strategies that we would use.
Thanks, Kate. And Adam, what are your thoughts about low-hanging fruit?
Yeah, absolutely. And hey, everyone, it's great to be part of this dialogue. I completely agree with everything that was just said. And often we utilize data like Kate was just mentioning, but ensuring that the data that we're presenting is valuable to the group that is going to be experiencing any type of change. Along with that, in terms of potential low-hanging fruit, which I'm defining as some of the easy wins, some of the stuff we're talking about may be a little bit more complicated, but some of the easier things are making sure everyone understands what they have access to in terms of evidence, right? What do they have accessible to them? How easily can they access potential best practice related things to the types of practice in their area? And Kylie mentioned earlier about the importance of leaders, and we have found that that is crucial in terms of trying to implement an evidence-based practice within an organization and within a local unit. And it's not just supporting the change, but it's really modeling it. It's using the words, it's using, hey, according to this recent systematic review, I just saw that blah, 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 blah. Or I just read this implementation report or project that stated in our area the outcomes could improve by, and starting to really model what it's like to have a culture that's based on evidence.
Okay, thank you, Adam. That's a really interesting cascade of answers, isn't it? But they're different perspectives, but they're all filling out key components, really, that help us understand the same thing. Leadership, the nexus between policy and how that engages, flipping it and looking at it from a patient perspective and what are the drivers behind language around patients, and then what are some of those qualitative metrics in the way care is provided and how do we understand them? How do we see inconsistency and consider that as part of the low-hanging fruit, as Kate mentioned? That's really helpful. So the next question is actually from Uganda. I think we'll get to Australia eventually, but this one is from Soroti University in Uganda, and it's a little bit similar, and that's a common theme here is, what are the best strategies for interacting with policy managers in order for them to buy in or accept that there is a need for change when one exists? And Carolyn, I'm going to throw to you first because of your extensive work with policy.
Yeah, I think it's, first and foremost, you point out the difficulty in health, the issue in health or the need in health. But I think you move quickly on from that to other areas. So this can, you demonstrate the economic case. That's incredibly powerful in policy settings, and that's also obviously incredibly powerful in health service settings as well. And I think, as you've said, you don't just keep throwing facts at people. You you try to understand from them. What is it, what are the questions that you need the answers to in order, so if we have a shared agenda around fixing something, and we usually do, what are the questions you need answers to? So what does your CEO or your minister or whatever need to understand in order to resolve this? And what are the other competing drivers that we can, provide answers to? Or it's just working within that space where they are, working within their reality, as opposed to coming at it from an academic headset and going, well, this is obvious and this is rational, because it's just nowhere near enough. And I think the other thing to say is that, we attention raise a lot in public health around different issues, but we also have to, if we get attention, we have to have the solutions right there and ready as well. There's no time for solution finding. The solution has to be, the pragmatic solution has to be ready, the tangible pragmatic solution has to be ready alongside the raising of the problem. Yeah.
It's a little bit ad hoc to ask this, but how frequently would you say that kind of response does get to a policy maker?
Well, I mean, in tobacco control, we've been doing that sort of consistently for 30 years, and we've achieved, gradually, but we've achieved a lot, and now we're sort of amongst one of the world leaders in tobacco control and smoking rates in the world. I'd say in other areas of chronic disease prevention, like diet, we're not really we haven't done very well in Australia around that. There's a long way to go. Yeah, and I think with the COVID work, that's been really productive and really helpful, and that's because I think we've come in, delivered something in the time frame that was needed, and built a relationship of trust, but also had a decision maker who was very, very oriented to best evidence as well. Yeah,
and I think you've got a strong, clear relationship with policy makers and policy leaders in South Australia that helps, this is a bridge that's come from both sides of the river.
Yeah, that's right.
Your side plus their side, and it's met very effectively in the middle.
Yeah, and it's hard when you're an academic because it's not what you're rewarded for. You're rewarded for papers and grants. And so I think that's part of what's wrong with the system of academia, that it's starting to value impact, but it hasn't really. So it's a sort of it's been a low value activity, which makes it hard to do. Yeah.
And I think if you're in the room as a junior or aspiring academic, then these are interesting questions, because it's easy to feel passionate about a topic or a problem and think, I really strongly believe in this, therefore this is a priority. That's not always the case, is it?
No, it's rarely the case.
Yeah.
I mean, especially political decision makers elected officials work on a completely different timeline to us. And I think the economic case is, they might be very sympathetic to what you think, but the Treasurer might not, and the Premier might not, and that's where the economic case. And the short term, for public health, the short term impact on hospitalisations, which is what, demand on tertiary services, obviously is a big driver.
It does come down to communication really as well. Like if you're having to communicate on multiple levels, communicating upwards to policy, but then communicating down and finding that consistent language, which is what you were talking about, is so that we might come from as academics, we might come with a certain view, but to change our language so it's meaningful to the group of people we're talking to, I think is really important.
Absolutely. I'm sure, Brian, you have some thoughts about this, about the nature of communication with policymakers to help enable practice change, those sorts of things?
Yes, I've worked with policymakers in a number of different jurisdictions, and I think there's a couple of things to recognise. First, they're human beings, so they're venal, they're ego-driven, they can be selfish, they're just people being people, and it's not always about the evidence. So I think the first thing you do is make sure you build, as you've clearly done, build a relationship. Google them, find out about them. Don't go onto LinkedIn because they'll find out that you've been on LinkedIn, you've been stalking them. Just be wary of that. Choose how you Google. But it is all about the relationship. That's the important stuff. But sometimes there's a timing issue as well. So the NPJ paralysis campaign, we've known since the 1940s that deconditioning, the loss of muscle and a whole bunch of things, we've known that since 1947, before the NHS was founded, that it was a problem. The Dangers of Going to Bed was one of the 20 most influential papers in the BMJ of the 20th century. 70, 80 years on. And I know other groups like the gerontological folk, they've been pushing this. But the timing was right. It actually started, by the way, in Broken Hill in New South Wales in the outback. That's where the campaign was born. But it was also about a chief nursing officer for England, Jane Cummings, who I'd known for quite some time. She took up the mantle and ran with it. And when you have somebody who's passionate about stuff and you've got a great relationship with a policymaker, that's when some of the magic happens. Yeah. Interestingly, a good friend of mine who was involved in all this, Pete Gordon, he got contacted, he works in this NHS system, and he got contacted by one of the senior NHS leaders, say, where's the budget centre for this whole campaign? He just laughed at, there is no budget. It's actually a bunch of people doing the right thing, which is informing policy. And that's the other thing I would say is, when it comes to policy, it isn't about the money, because sometimes money counterintuitively can stifle innovation. What's changing in smoking is the attitudes and the culture and all of those things informed by the evidence. But for youngsters, smoking just isn't cool anymore. No teenager wants to snog a smoker. That was as much about it as anything else. So it isn't only about the money.
Yeah. I think we've just discovered how to change teenager behaviour. Here on Q&A. We're solving everything today. How awesome is
Would you
that?
snog this person? That's why menthol cigarettes are being banned in the States, I think.
That's probably right. Now, Kate, you work across, if I can phrase this carefully, somewhat bureaucratic systems in Queensland. Not of your creation, obviously, but you work very effectively across hospitals, organisations and systems to facilitate implementation. Is there an element of negotiation with policymakers within that context that could be helpful for us today in thinking about interaction with policy managers to get buy-in or uptake on wanting to change practice?
Yeah, I think you're right, Craig. We now have a very complex system where we work across multiple public and private facilities across a very large geographical spread across Queensland. Some of our facilities, they have, there's 1,200 kilometres between sites, and some of the challenges that come with that from a local policy perspective is we have all of these different facilities with their different policies and procedures and approaches, and we're trying to bring them under one sort of statewide system and approach to that. And that can be really challenging from a EBP and an implementation perspective because we have such differing level of knowledge as well across those different facilities. And in terms of engaging with our policy managers and our staff, we really have to know our particular audience and what that level of knowledge and skill is from a EBP perspective, because we have some sites where we still are going back to having local policies and procedures which are just what we've always done. And I know we've come a long way in moving away from that but from a local health perspective that still does occur. So we have to be really aware of how we approach these different areas to bring them on that journey. So we have to be really adaptable in terms of how we approach that. And from, engaging leadership and the people involved in developing policy across our organisation, some of our strategies are around sharing the evidence with them, and also, going back to basics around we need to make sure that, the local policies and procedures that we are developing are in line with the latest evidence and research, and making sure that we are referencing that within our documents. And I guess the other big challenge for us is making sure that we're aligning what we do to accreditation and to the National Quality and Safety Healthcare Standards as well, and that can be a really big driver for us in terms of engaging people on that journey as well.
Okay. When I was a practicing clinician, I'm a registered nurse. I worked in a hemodialysis unit, so plug people in, dialyze them for 3.5, 4 hours, depending on their status, unplug them and then get them back 2 days later to do it again. I was a good nurse, I suppose, in the sense that I was always washing my hands, maybe 14, 15 times a shift. And then you notice that your hands are breaking down, and I thought it was the paper towel. So I went to the library after my shift, not during my shift, because you never get time to go during a shift. And I looked up papers on hand care, and at that time, there was a paper I found that said you can use warm air dryers instead of paper towel, and you get reduced cracking and bleeding in your fingers, and it reduces risk of transmission of infection, nurse-patient or patient-nurse. And I wanted to change practice. So I brought that paper to handover and I read basically the abstract of the paper and said we should throw out paper towel, we need to buy some hand blowers and look after ourselves so that we decrease our own pain but also decrease the risk of infection. I made maybe only 30 mistakes in that approach. I assumed that one paper was evidence, but there's loads of papers and they all said different things. And I didn't manage my messaging at all. So I got everything wrong as a clinician in thinking about how do I change a practice based on what I think is a good idea. Adam, as an extension of that question that we've just had, how can a clinician sell their idea or their initiative to management so that there's potential for it to become an organisational reality?
Yeah, that's a great question. I think your approach, at least you went for it. You started down the path. I think the important factors are what's the outcome? What's the goal of the change we're looking at here, and how is that going to benefit our patients? How is it going to benefit our staff? What outcomes? How is the data that we're going to measure that collected? Is that data that we're collecting reliable? Right? Because it's we have to move past the perspectives or perception type of metrics when you're trying to implement something large and move to metrics that actually will be valuable to the management. So I think whenever we're trying to implement something new, we often start with the most senior leaders to say, listen, before we put a lot of resources into this, is this something that you support? Here's our proposal. Here are the metrics that we believe it will improve, and here's our timeline. And then we move forward based on that. So I think utilizing that approach and utilizing the fact that you can show that there is strong evidence to support whatever change you're looking into. Sometimes there is and sometimes there's not. And perhaps later we can talk through a little bit more about how you have a culture of evidence-based practice and still allow for innovation when things haven't been fully proven or there haven't been formal research studies to prove one way or the other. How do you stimulate that? And I think a lot of that can come with having a well thought through proposal with a lot of structure around how you're going to measure success.
Pre-planning. What about for you in the room here? If you're been through this experience, have you had this experience? Do you have some thoughts about pre-planning for implementation or message communication? Can we have a microphone, please, to Alejandra?
Thank you.
So would you
Can you hear
please introduce yourself before
Okay,
you?
I'm Alejandra Piñero de Plaza from Flinders University, postdoctoral research fellow, knowledge translation. Very long, that's it, I'm off. So I got a comment based on my experience in marketing science. And I have seen very few points that I think are relevant. We are focused so much on evidence because we are scientists or clinicians, and that's what matters to us because logically it makes sense that will improve using the dryer or the towel that you were talking about. But there is evidence in terms of communication and marketing science that talk about a little bit of the heart first and then the emotion and then facilitating behavior. So one thing is the evidence that we have to guarantee the workout and is sound and strong. And another thing is selling this product to our audiences, which could be policymakers, educators, and so on. So what marketing science and behavioral science, and we got an expert there in the panel, talk about is first emotion, then convenience, Very easy to use in psychology. They talk about fluency. So it's something that you don't even think about. It's like a habit, and someone else mentioned that before. Then noticeable, attractive, and after return on investment. We were talking, oh yeah, you have to demonstrate that you're saving money. Yeah, all of that has to be there. That's the basis. But the most important thing, like we heard before, hearts, emotions, convenience, habits, how this has been done for ages here. Do you think you're going to come today with this fantastic, very return on investment? What happened with products? How many products do you have in supermarkets? They can be even better, healthier, and whatever, but you don't buy them. Why? Because they are not fluent, they are not noticeable, they are not attractive, they don't form part of your habits. And that's what we have to do, and that's why we have experts, like we have focusing on that.
Yeah, thank you. Thank you very much. It's an interesting move into thinking about behavioural science and how our choice environment predicts our behaviour as well, isn't it? Yeah. What about for you in the audience? Let's do a quick poll. Just because you're all postprandial now and we need to know that you're awake. Who feels that they could, at this point in time, sit down and write an implementation proposal for a hospital or health system or service? Pop your hand up if you're 10 out of 10 confident you could get that.
Tumbleweed.
Just wiggle your fingers if you're awake. No, I can see. But it's challenging, isn't it? Like, I think we actually have a room full of fairly talented, clever, articulate people here. But these are big challenges to think about. How do we put something together that meets a need, that communicates the right kind of message, and does so in a way that will move others to join us on a particular journey? You know, those are skills that were not part of my undergraduate training. Although I'm sure things have
Just to pick up that
changed.
point briefly. I worked as an exec director in the NHS, in a large 1,000-bedded system. And when I took the role, because I'd been in research, education practice, and the CEO said to me, you get paid what you get paid because of the pressure you will be put under in a sustained way. There was no breaks ever. The job description didn't have number of hours worked. It was what is necessary to fulfill the obligations of the contract. So, and she was absolutely right, you know, never worked more intensely, but also it's a different lens on the world because it is a much more complex, and that was a big striking difference between working in academia as a research fellow and working as an executive director, who was also the clinical director of the emergency, or a couple of emergency departments. So when it came to writing board papers, it was a very different skill set, a very different lens that needed to be applied. Because we were creating policy all the time within a policy framework from the National Health Service, which would shift. We would get, and you know, this happened in research as well, you'd get a call at midday from, you know, from the centre to say, we need to offload some funding, we need you to put in a proposal to do this piece of work. You just create some sort of nonsense and throw it in. I'm sure that would never happen in research in this country. But you're dealing, you have to be really nimble. I think that's the key point. You don't necessarily have time to think it through, because that's a luxury you don't have in the sharper end of both strategic and operational policy development and performance.
Yeah.
And when you're trying to influence boards, you have to think in their world, be them, not you. I think it's also for what are they thinking in this?
Yeah.
How am I going? So you saw Leslie going. She's got a board meeting this morning. She's going to have to be in a very different headspace to deliver the big and small political complexities of a board.
Yeah. Sorry,
I
Kyle?
was just going to say, I was actually quite happy to see that nobody raised their hands just then, because I think for me, if somebody said yes, they were willing to write a proposal right now, right here, without actually engaging with the people who were going to actually be doing the implementation, I think I would be more upset with that. So I think that was excellent that we got a 0. Well done.
Sorry, can we just wait a sec? Can you get a microphone and introduce yourself?
If you missed it at the start, I'm Zoe at JBI. Brian, you've just hit on something that perhaps some of my colleagues will eye roll a little bit because I bring it up all the time, and it's the role of empathy. And I think whether you're in a caring position, caring for a patient, whether you're in policy, whether you're a clinical director, no matter what your professional role is, I think that there is a critical role for empathy in all of the things that we're talking about. And I'd be interested to hear what all of your opinions are on that. Although I think I've heard yours now.
Carolyn, would you like to speak?
Yeah, I mean, I think I totally agree, and I think it's empathy, it's understanding where the person you're trying to influence is, which is being realistic about their constraints and changing your perspective to try to understand the perspective of the person who you are asking to change. And I think that applies universally, really. Yeah.
I would agree with that completely. Like I think that in order to be successful, you have to work with all different kinds of people. You have to have an understanding of where they're coming from, what their needs are. I think to be successful, you need that understanding and empathy and emotional intelligence of other people for things to work. So
it seems obvious, but we don't talk about it.
Yeah.
Look at the literature, particularly around implementation. We do not talk about it.
I also think that there has been a huge, the focus really predominantly has been on the evidence for all these years. It's on evidence, evidence, evidence. You have a look at where energy is mixed, there's around synthesis. We see there's multiple methodologies on how to synthesize, which is all very important. And I'm happy to now sort of see that there is this shift to sort of more, okay, we've got all of this evidence, but it's not enough. Like before it was, we don't have the evidence, so therefore that's why we're not practicing, doing best practice. Well, we've got evidence now in a lot of range of areas, particularly the slide that Leslie showed this morning, like asthma. There is a lot of evidence in the field of asthma. So it is very clear that there are other things going on that we need to have a look at. I think we have a high-level understanding of what they are. We know it's leadership, we know it's culture, it's change, and context is different for everybody. But we do need to invest more time in all those areas to have a deeper understanding of what it means, and sharing that with everybody. Like events like today, I think are really crucial because we can share our knowledge and share our understanding. And if somebody walks away thinking, oh, that might be able to look at that for my area, I think that is great.
Yeah, thank you.
Very quickly, I'll just say it very briefly, which is that compassion is a belief system, whereas empathy is a skill set. And we need to focus on building that skill set. Sorry.
I hope someone wrote that down. Ed?
Along with all of his other quotes today.
Thanks, Craig. Ed Aramataris, JBI. It's just touching on a bit of what quite a few people have touched on, over the last few comments. And I think the first part here is, Craig, in answer to your question, could I write an implementation proposal right now? I could, but it wouldn't be a good one. And I guess...
I knew that, Ed.
Yeah, thank you. Because I know what I'm talking about, we all know that. But,
and
I guess that it really touches on, we saw this also, I think we wind back a year, when the world was hit with a new virus. Health systems had to respond. We had no evidence in relation to this virus. And experts made different decisions. Some went towards herd immunity, some went the lockdown pathway. And also listening to what Adam mentioned about where there is no evidence and having a plan. We talk about change and behaviour change. And when I think about health, the myriad, the gamut, the scope of decisions is enormous. From one end where it might be life or death, right down to the opposite end of the scale where it might mean that someone walks out with a smile on their face instead of feeling a bit sad. But in all of this change, how do you build in that opportunity for failure, or where there's that risk of failure? How do you manage that? So I think it's a real thing, but I can't wrap my head around it. I think it's something that's hard to do. I'd like to hear your comments.
I think Adam might have a good response to that.
I feel like you're leaning forward for a reason.
I will give an answer, but obviously I'll be more than happy to defer to Kate. I know absolutely there's an answer I always gave, but certainly Adam and Kate might wish to.
Adam?
Sure. I think it's a great point, Ed. that we don't want to stifle risk taking, because it's with risk taking is where we see improvements, where we see creative solution making. And I think part of, to circle all the way back around to Zoe and bringing up empathy, I think understanding where the staff are, I'm speaking in terms of the hospital staff because that's my context, understanding where they are at and what they can handle. And you know, our teams are tired right now. They just battled through a very intense year. So if we tried to just implement change after change after change, even if the evidence was supportive of it, it would be extremely challenging to push through. At the same time, we want to try and keep our teams engaged in their practice. And often one of the tactics we use is to engage the patients or the clients and actually empowering their voice in the story. And we have a lot of patient advocacy groups where we have current patients, former patients. We will have meetings around a change implementation and try to get patients who are currently in the hospital part of the group making the decision on should we do this or should we do this in one way or the other, because their voice tends to be what hits at the heartstrings of why everyone is there, and you know what brings people to work, what fills up their cup with the passion for the work they do. And sometimes that can get lost with the busyness of and the complicated nature of the work that has to get done. And oftentimes when we can take a moment, step back, meet people where they are, acknowledge the fact that we're all exhausted, tired. We've never had a year where we had to run this hard. We talk about the amount of change that went through in my current organization in the last year buried the amount of change that went through in the last 10 years. We were implementing a new way to manage COVID patients basically every 2 days, and there was very little evidence to guide us. And we empowered the staff to be part of the decision making. We're like, how do you think we should do this? And got them involved with it. We even talked with the patients who were there and saying, do you think this would be okay? You need to challenge us if you see things that you think may not be appropriate. And I think finding those nuggets in to keep up the not only best practices, but to help people think that they can take a chance and know that certain types of failure are acceptable. You know, we often teach, you know, fail fast, fail hard, learn from it, and let's move on. And I think sometimes without the safety net that you feel that you may or may not have, sometimes you won't get those really, really strong nuggets of innovation that will help improve care.
Thanks, Adam. Kate, do you have some reflections on this?
Yeah, thanks, Craig. I think my comments are very much in line with Adam. Like, we have done a lot of different implementation projects throughout our organisation. You know, some big organisational change, some smaller local projects. They're not all a success. And so when we talk about implementation and when we're promoting the use of evidence in practice, we do it from a perspective of this is about building capability and building the capacity of staff to be able to have that confidence to use evidence and to know where to go to get evidence and how they might begin to make some change to their practice when they see a problem. So we're very much promoting it as this is for the individual. This is an opportunity for you to learn and to develop, and it's going to be a skill that you can come back to and that you can continue to integrate into your clinical role. And I think that's where we see a lot of success from the types of education we do and the types of projects we do and how we can integrate that at all different levels from, yes, let's look at local policies and procedures and where we can make a change and align them to best practice, to smaller projects around how can we improve the care for patients in, our local cancer setting and things like that. So, and much like Adam, we are, we're promoting through all of those programs and education, we do the importance of the patient perspective and consumer involvement and talking to the patients about what you're planning and what you want to do and sharing that and using that feedback and that comments from patients and from our consumer groups as well in helping to shape the change and what that might look like.
Thank you, Kate. Ryan, did you want to?
Something I used to say to my team constantly, you can't just say it once, you have to keep saying it again and again, which is, and this is in my service improvement teams and the emergency teams I was leading, which was, if we only make 20 mistakes today, it's a good day. Now, the subtext of that was, these are not women and men who go out to make a mistake. It was about fostering a culture where they were safe to have a crack at stuff. And often it would fall over. But the real trick, I think, when encouraging people to fail is when it fails, you have their back. Because psychological safety is the determinant of a successful team, where people feel that if it goes wrong, people have got their backs, but there's also people who will call them out, but they feel safe to call them out for doing stuff. Because that's what makes a team successful. That's what keeps to take an example from sport, the All Blacks and the Wallabies, what they do is when they are at their best, they're driving their own performance culture because they want to be even better. But what they'll do is they'll constantly try stuff, which is why you see these tries that are scored and thinking, man, that's gold. Because they try and try and try and fail and fail and fail and then have a go again. So I think that's a really important part is that psychological safety. Yeah. That is safe because people don't go to work to harm people, but they need to feel it's safe to have a try at different things.
Yeah. I think that segues beautifully with what Leslie was telling us this morning, wasn't it? About moving to, if you want to transform your health system, you don't create a logo and a catchphrase. You work with people. Because implementation is not a technical process, it's a human innovation. And so you've got to create the capacity for people to have safety, support, and be able to take a risk in order to see what will happen. So those are really key things. Taking a risk does mean, if it doesn't work, you might lose momentum. I'm just wondering, from the floor, there's two ways maybe you can lose momentum. One is if something doesn't work, and the other is that key members of your team get removed from your team because they get allocated to COVID care or something else. And so you have staff turnover issues as well. Is this something that's been a challenge for anyone in the room today? I'm seeing a nod. Does anybody want to share a quick story about that? I'm not looking at the person who nodded because that might be intimidating. All right, so
is it about losing momentum, or is a bigger fear losing face?
I would be scared of that.
Yeah. Because people, when you put yourself out on a limb and it fails, the risk is you lose face. And I think that's what people fear more than losing momentum.
Yeah. Kate and Adam, do you hear this ever? Do you have to grapple with this issue that you might want to work with daring clinicians, but maybe they're scared of failure because they might lose face? They don't want to be a failure.
Yeah, absolutely. I mean, I've actually seen a few implementations just fizzle out because they lost their passion because they met some resistance initially, and they were scared that if they kept pushing, that they would be perceived as one of, a little bit out of touch with what is really happening with their colleagues. I'll say one strategy that we are trying to push more into is being transparent and highlighting, almost celebrating the failures to show that that's okay. And saying, you know what, this project didn't work and I want to do a poster about it. Because it's not sexy. I didn't show any good outcomes, but I followed a process that, just didn't show improvement. And, next time we'll do it in a different way. And I feel like if we do that more, the concept of failure won't necessarily be perceived as a negative if you did it in a systematic way. It'll be perceived as you went for it, you tried, you didn't get the air blow dryers in, but next time we'll learn from it and take a different approach.
Adding something there. I also think, just hearing that, it sort of leads out that having regular like I come back to communication, but that regular communication, that regular checking in with everybody. So you're not just going to try and implement something, change a whole statewide practice, do it once and then never check in, reevaluate. It's the constant checking in process and looking at what's worked, what hasn't, and not only, I guess, celebrating the failures, but the small successes, I think, as well. So it's not just the end point of did it work, did it not? Okay, it was a success or failure, but looking at the smaller little bits along the way, I think that's where we need to be focusing on as well.
Kate, would you like to add anything at that point around fear of failure?
I would, just reflecting on what Adam was saying, one of the key aspects for us in terms of our program and how we approach implementation is mentorship. So really being able to have some support there for people who are trying to make change, and somewhere where they can come and talk about any of the issues that are coming up or the challenges that they've had in practice, because most of the time it's things that we've heard before. There's no leadership support, or, the culture is not open to the change. And, so they're things that we can sort of talk through and address. So that's been a really key aspect for us, just, having a mentor for them to work with, and also just having those networks where they can come back and share. Because, often when we come back as a group and we talk about where we're at in terms of implementation, they're all seeing the same challenges. It might be in a medical ward versus a cancer setting, or even in a neonatal critical care unit. The challenges are very similar. So being able to have that support network is really important in getting them to continue and driving change.
Thank you, Kate. Earlier you heard Carolyn talk about the pressure to publish as an academic, and that's part of your survival. When we fail, there might be a fear that this won't be able to be publishable. But recently, JBI Evidence Implementation, which is an international peer-reviewed journal with a strong editorial board, a good impact factor, quiet side plug. We published an implementation report where out of 7 criteria that they were trying to improve practice on, they improved practice by 15% on one criteria and not on any of the other criteria at all. But it made it through peer review, blinded double peer review, fairly easily, not because of the significance of the results, but because of the significance of the learning experience that individual went through in engaging with their organisation to try and initiate a change process that later we found did not work. But they unpacked that whole process of how they engaged with who and why. And they dealt with that across all the spectrum of leadership, because hospitals are horizontal and vertical, and you've got to get your communication going horizontally and vertically pretty much at the same time, using the right language for those groups. Otherwise, bits of it fall off. And it was a really compelling piece of work, actually. But if you look at it based on outcome data, it was a failure. But in fact, what we all learned by reading that manuscript was really deep knowledge about how expert clinicians can successfully engage and develop their knowledge of their own organisations. And I actually think a lot of us, like I was an incredibly naive clinician. I had no idea how to talk to a manager. So these are important learnings that can come whether or not we characterise them as success or not.
If I can just add, I also think too that we talk about that the setting the culture might not be ready for change. It might not be ready for the change of that particular project, but clearly some other kind of change is necessary then, because if the culture's not ready, then that in itself needs to change. So I think that's just an interesting.
It is a good point, isn't it?
There is a threat at the moment as well, of course, because journalism has so much pressure and they've got so many papers being submitted to them. And I can't remember, is it UK or US Pediatrics, about 18 months ago said, we will no longer accept qualitative studies. And that seems to be a growing issue in terms of publication. And BMJ is BMJ Pediatrics Journal, was it?
The main BMJ journal.
The BMJ Journal.
Yeah.
And I think that constitutes a real threat, because quant is great, it's valuable, but there's two sides to the story. And people, it's a great US poet, Rucker, who says the universe is not made of atoms, it's made of stories. And it's the qualitative, the story-making, sense-making that people are, that's a richer story for often. And that often, I think, probably has a bigger impact on practice than all of the numbers under the sun. And I was lucky enough, I went to Oxford University, and at New College there was a guy called Justin, who was a Rhodes Scholar from Australia. I think his PhD was 54 pages long, doing maths. And he said to me, you and I, because I was doing an educational master's degree, he was doing a PhD or DPhil in maths. He says, you know, the two of us are we're actually the same. We're both junior deans. We're both storytellers, because all scientists will ask the same story that a qualitative researcher will say, what story is the data telling us? He says, whether you're a physicist, an astronomer, a mathematician. And it was one of those great big aha moments in my life as a researcher. It's all about the stories.
Okay, thank you. Can we get a microphone to Susan?
Thank you. There's some, such a rich discussion, and my brain just keeps thinking of all these different examples. But I just want to pick up on the issue around how ripe an organisational culture is for change. I think that we tend to think that change is the answer to everything, and if people are against it, they don't want to play by the rules, and I think that's a really dangerous environment to be in, because the reality is every day when a clinician comes to work, they work within an environment of change. Their patients change, their scenarios change, the doctor change. They're in a constant place of change. But what I have seen, and I've been in the health system for many years myself, is that actually clinicians have no opportunity to embed the change deeply. They're given little bits, run with it, tomorrow something else, government change, something else. And in fact, people are questioning why, what is the value, what's the benefit for the patients, are we changing, what is actually the purpose of the change. And so, like any good sports person who has to practice and practice to hone their skill, the very thing we don't give clinicians opportunities to practice and to embed and to get really confident about what they do. We just give them this sort of piecemeal stuff. So I think, taking from what Adam and Kate and everyone is saying, yes, people need to have the opportunity to take risks and to be comfortable, to be celebrated around that. And Craig, absolutely right. The literature, even publishing, is biased against publication that have where the intervention is not positive. We know that already, in many fields. So all we get in the literature is about what apparently works, but we don't hear a lot about what doesn't work, which would help, as well. But we also need to not think that people who might not go on the bandwagon, that they're the ones who put on the brakes, because I think they might be actually the ones who want to do what they do well. So I think we just need to be careful around, again, the language and the thinking. And as Brian said too, we need to give people opportunity to unlearn. So I always say health is like a big USB. We just keep on uploading information, but we take nothing off the USB. And so people are overloaded, overwhelmed, and tired of change.
Yeah. Thanks for that comment too. I mean, maybe I'm trying to find a really clever segue and I can't, so I'll just say the question. This comes from Dr. Jude Tabin from the Philippines. If you're online, then here we go. This is your question. Did COVID and COVID research teach us anything about the connection between education and the organisation and delivery of care? Do you feel like we've learnt lessons from managing COVID in terms of the way we educate and prepare clinicians? Sorry to do this to you.
I can't really answer that. I think because I don't I don't have experience in that world and in that space. But I mean, someone else might be able to. I can talk about evidence for COVID, but not the.
Yeah, I'll throw to Adam first then. Adam, in UCSF, do you feel like we've learnt those lessons in terms of how we educate in such a way for uptake into practice?
Absolutely. It was a constant learning for us. And, especially initially when we were converting units to care for, 100% COVID patients, and the workflows that we were doing without good evidence and best practices, and we were creating it in the moment, totally changed how our typical structures for rolling out education, at least on the direct practice side, we were doing just-in-time creation of best practice and then whipping it right back around and doing just-in-time training for the person right next to us. And that was, it was so fluid and at first very chaotic. And then the staff understood this is the situation we're in, and they learned to trust it. And so it really taught us the power of having the right people doing just-in-time training in the moment that staff could trust. And when it came from a reliable source, that they would go with it, because there wasn't an extensive amount of time for every single individual to test it out on themselves. We sort of had to just push forward. And that was a unique situation because typically we get to do a little pilot in one area, test it, measure it, maybe make some changes, and then do a pilot in another area. That was not the situation over this last year. We were just having to make very rapid decisions. And because of that, we got used to finding out information right before we were walking in on how we were supposed to do something. So I think we learned a lot of lessons with the urgency of how we had to provide care.
Like at Mater. Mater's a large, disparate group, really. Was that a challenge, trying to connect education and development of staff for care provision?
Yeah, absolutely. I mean, we didn't have the same challenges with COVID that Adams has seen in the US, but, it certainly, it required a lot of different approaches to how we do different things. It also came at a time where we were becoming this sort of multi-site organisation, bringing on other facilities across the state. So, very rapidly we, had to utilise the resources that were coming out, all of the different evidence that was coming out, being able to pull that together quite quickly for our clinical leaders who were sort of making decisions about what we were going to do if we had an influx in COVID patients. We certainly saw the uptake of technology in how we approached everything in the organisation. So how we approach meetings, we went from having face-to-face meetings to everything being online. All of those kind of approaches, changed our whole approach to education in general and how that happens across the organisation. And then also coming together as sort of one Mater across the state, we realised where there were really big gaps in terms of education and and rollout of equipment that we needed in terms of our N95 masks, and which site had access to particular supplies, resources. So there was a whole range of issues that came up through COVID, and we've certainly learned a lot of lessons as well. And we've certainly learned a lot of more effective ways of being able to do things as well, and that reaches across to EVP and our rollout, and it influences how we can connect with staff. Like, everything used to be around, it has to be face-to-face education, and it needs to be, in certain clinical time, and now there's just so much more access to technology. Everyone's on Teams. Meetings and education can all be online now, and that has really just opened up our access to be able to connect with people in a lot of different ways.
Okay, thanks, Kate. I mean, one of the motivations for education, particularly within an organisation, so not the undergraduate program, but specialist education you might do within a hospital, is really to help drive the coordination, the organisation and delivery of specialist high quality clinical care, but it can also be used in a short course format to encourage uptake and use of evidence-based practice in an institution. But there's always that challenge of organisational leadership, because without organisational leadership driving it, to be honest, and we talk about top-down versus bottom-up, and there's quite varied views about that, but without organisational leadership, it's not really going to happen, is it? So how do we strengthen organisational leadership to encourage uptake of innovation, change, evidence-based practice, whatever word you want to call it? How do we strengthen organisational leadership to make that, to enable more of that in our systems?
First thing, counterintuitively, you don't change the leadership every couple of years. Central Adelaide ran through 10 CEOs in a decade. Leslie's now here 2 years. She's almost on long service leave. I work I've got a 100-day annual contract with Canterbury District Health Board as Director of Service Improvement. And it's one of the top 5 most integrated health systems in the world, alongside Kaiser Permanente, Intermountain Health in the States, Salford, and I can't remember the other one escapes my head right now. And they had a leadership, an executive leadership, that had been there for the best part of a decade, all of them, There's been ructions in the last year for a whole bunch of reasons, and 7 of the 11 left because of very poor governance, among other things. Really outstandingly good people. Next year, all 20 district health boards and all 30 of the PHOs in New Zealand will be abolished. And as NZ, New Zealand moves towards an NHS model, at the very time the NHS is moving to look to integrated care systems that New Zealand does. Because structures don't change. Structure is your anatomy. Process is your physiology. And your process also fits in the people bit. That's your physiology. So having a stable leadership is critical, because what that comes back to is trust and empathy. If the average tenure of a CEO in Australia is around 19 months, and it's a double loss for 2 reasons. One, if you don't like the CEO, keep your head down, they'll be gone in about a year and a half. If you do like them, what's the point? Because they'll be gone in a year and a half. So it's a lose-lose in healthcare. And you need them to pay, because you only build trust, and organizations only progress at the speed of trust. So capability, leadership, all of those things, the foundation stone is trust. And that takes time. Because I'm not going to give trust to somebody, some random I've just met. I need to know what they're like, who they are. Is their lived values the same as their espoused values? And we've got outstanding BS detectors, all of us. We know when people are speaking truth and when they're speaking the other stuff. We know it's how they actually behave, and we will be watching them always. And what I say to leaders constantly is, you're not off duty for a heartbeat. Because how you behave to the person who serves you the tea and coffee and the sandwiches, somebody sees you. You're not off for a heartbeat. So the role of leadership in sustaining successful change, it's as much about your behavior as about your qualifications, your integrity, and everything else. It's about your decency.
Yeah. What about from the floor? Does anybody want to be really, really daring? You don't have to stand on the table and say, "Captain, my captain." However, do you have some thoughts around strengthening organisational leadership to promote uptake of evidence-based healthcare? Can we get a microphone, please?
Just listening to Brian again and thinking about trust, about improving and the language and how we refer to error, and going back a little bit about failing and the recognition of failing within the clinical and research environment. So if we think of a parallel situation, we have it in technology. So people in technology, they don't go and say, we're totally wrong, that's it, this machine doesn't work. What do? They have a process of optimization, they're cyclical. So they don't talk about we fail, they talk about opportunities of improvement. Those opportunities of improvements are barriers. So just small barriers, and then we understand. If we fail, this is not publishable. No, we have opportunity of improvement, and this is publishable because we know where to go from, where to go next. And if we think about that in terms of leadership, then perhaps if we have a system where trust is kind of automatized through opportunities of improvement, then we have a leadership that feel like progress, like you were saying, the connection between progression and trust. If you are within a system that is constantly optimizing itself, not finding errors, then you have more trust and better leadership. Is that a theory?
No, thank you very much. Good,
I just think it's interesting because it seems to be sort of like a lot of common themes between everyone's comments. So, you talk about trust and having consistent, reliable people in leadership, and we're talking about having. Adam talked about what worked for them was being able to have trust. The person trusted that they could deliver the information, and that's what you were delivering is exactly, synthesizing it, and that information was trusted as the evidence source. So I think, it's interesting that it seems to be like a core component that for implementation to be successful, we need that trustworthiness and reliable, that we can sort of count on each other to be able to move things forward. So it was just more of an observation than anything else.
So sometimes the messenger is the message, in a sense. Yeah.
And if you don't mind, if you look in the recent politics of the United States with Biden and Trump, the messenger is the message.
Yeah.
For good or ill, I make no judgment.
Right, now for your academics in the room, you're going to love this question.
I'll get my coat.
This comes from Dr. Alabdani, who's a postdoc research fellow at University of South Australia, Adelaide, the best city in Australia, with the best wine districts in the world, even better than California, Adam. So, sorry, the question is there value in adapting and designing implementation science frameworks to increase translation of evidence into practice for specific fields of inquiry? And are there methods that could help increase this translation? So I'm going to segue from that to say, Brian, we talk in implementation science, translation science, knowledge translation, we've got all the lingo. And we've got more frameworks, models, and theories for implementation than
throw a stick at.
Exactly, then you can throw a stick at. What's a consumer to make of all of this when they walk into the hospital system?
They wouldn't have a clue. Not a foggy. What is triage? And that's the first experience you'll often have in an emergency department.
Yeah.
And what is the otolaryngology? We have a lot of TLAs in healthcare, do you notice? They're 3-letter abbreviations, you know? Like, what is ENT? I mean, does NAD mean no abnormality discovered or not actually done? You know, we use this linguistic shorthand, which completely bamboozles even, you know, people who are pretty smart. So I think that's one of our big challenges, is how do we make it simpler without being simplistic?
Kylie, are we just making language complicated to make ourselves sound more impressive?
No, I think, to go back to your question beforehand, though, around all the different models and frameworks, I think what that shows is that implementation is complex and complicated, and there is no one model that's going to fit everybody globally across the world. So I'm okay with there being lots of different models and frameworks, and I think at the end of the day, if people can adopt something from that framework or model and something from that, and it works for them, that's what we should be going with. I'm not sure, you know, we try to sort of encompass everything all into one little pretty picture, and you can't do it. I mean, we've seen what implementation, when we look at them, you know, people are delivering presentations on it. It used to look nice and linear, and now it's this squiggly line mess because we know it's complicated. Yeah. So I don't think we're going to ever come to sort of an easy answer around it. I think it's just more identifying what the challenges are for us.
Isn't that with the great W. Edwards Deming? I loved his line, which is, all models are wrong, some are useful.
Yeah, that's a great
Except
saying.
for the model the
Of
JBA.
Of course.
That's the one.
And Adam and Kate, obviously.
Yeah.
Couldn't agree more. Zoe, thank you.
Craig, I think that's a really interesting question about the consumer perspective on all of this, because we've all been at this game for a very long time now. You just don't know it because I colour my hair, but really I'm the same colour as Craig. So we've got a lot of experience, right?
Like mine.
When I first started in JBI 20 odd years ago, my dear mother, who's now in her 70s, used to say to me, she knew a little bit about what we did, but not a lot, but she used to say, when you go to work, can you just ask your nurses about this thing, this problem or whatever? She knew I worked with nurses, but that's about it. As she got to understand what it is we do, she started to ask questions like, can you look up the evidence for? And I always found that, and still do find that, a really interesting, you know, evolution in her thinking and understanding. Because as somebody who has never been a clinician, I don't have a clinical hat to put on, I still remember being quite astonished when I started working in this space that this was even a consideration. What do you mean health professionals aren't using evidence or don't know the evidence for something? Because we put them up on, nurses, doctors alike, put them up on this pedestal and assume that they know everything about everything to do with this and what goes wrong. And I would hazard a guess, I know it's 20 years later, but I'd hazard a guess that most consumers would still be quite astonished at some of the conversations that happen in these rooms talking through some of these challenges. Because I think that there is an absolute naivety about the challenge associated with evidence-based healthcare and the knowledge of, you know, nurses and doctors and other allied health professionals.
Yeah.
I think, you know, it'd be interesting to spend more time thinking about that, going back to, you know, we're talking about people, caring for people.
Doctors especially, they're the secular priests in a modern age where religion is being replaced, and we deify them. We have the voice of nursing has certainly been amplified in the last particular 18 months. But you're right, I think, you know, and you know, Patty and I would agree with you. People will be shocked. But also, particularly as nurses, we're often used as navigators and we're translators. So patients would ask us, what did the doctor say? So we speak medicalese and patientese with ease, and our role is the navigators. And also as in the family, you know, as a family nurse, of course, I was the one who was navigating. You get family members coming up to you and say, "Can I show you my rash?" And you say, "Well, not on the dance floor, if you don't mind." That's kind of your life, you know.
It is, isn't it?
And I think it's something about there's something other about that language, and we need to deify, because it's about something that is mystical and mysterious that people don't understand.
Yeah.
And maybe that's something in it. Maybe we shouldn't knock it too hard, but certainly we could benefit from being more humble as well.
So we should shake the tree a bit, see what fruit falls, but maybe not pull it down. I mean, Adam, you run 2 implementation programs really targeting engagement with clinicians. Is there a story there about the value of models from a clinician perspective? Is implementation really complex for a clinician, or is it more instinctive and intrinsic than that? And are models not so relevant at all?
Yes to all of that. I think before a clinician really gets into a complicated implementation, they don't really know all of the elements they're going to encounter. And without some structure, some model to guide them, they can easily veer off path and, you know, can hit some barriers that may be able to have been prevented. So like Kylie said, there's no one secret sauce. There's no follow A and B and you will always get to C. Like that doesn't exist, mainly because of everything we've been talking about. We are dealing with people and the readiness for change and culture and, you know, how strong evidence is and all of that. That being said, the majority of clinicians, and to Zoe's point, the majority of the consumers have no concept of what these models are. And sometimes that's okay, especially the clinicians in their busy world. They've got plenty of stuff that is taking up their cognitive load. But if we do, and I think some of the successful programs that we've been running through implementation in a formal way, where we do have structure and we do have it based on models, help guide the clinician in the implementation process. You know, even just thinking ahead of time, here are some barriers you may come across. Let's think about them way before you come across them. Because ideally, if we think through them enough, we could potentially avoid, you know, the barrier altogether. So I think there is I think that, yes, it is very complicated, especially if you're trying to implement a change that will have any impact on time of your colleagues. If you're trying to implement anything that will increase the documentation or be perceived as unnecessary, there are major obstacles that you have to overcome, and those can be very complicated.
Great, thank you. Our next question is from Dr. Kibibi, who's an associate researcher for the Ethiopian Institute of Public Health in Ethiopia. And he asks, what are the strategies to create awareness amongst policy decision makers to use evidence before making a policy decision? And I'm interested in this. Years ago, I went to a policymakers conference where one of the speakers was a social science researcher who said, policymakers use evidence the way a drunk uses a lamppost. It's for support, not illumination. But I feel like that's been challenged today. Like listening to Leslie talk, listening to your talk, Carolyn, there's a lot of engagement around evidence now. But I think the question is still worth teasing out. So is it awareness amongst policymakers that maybe they should think about evidence, or are we just unaware that they're already deeply invested in evidence? And is that a gap? Is that gap a problem?
I think it probably depends on the policymaker, to be honest, and I think that there's probably a lot of variability. I mean, one of the thing that first came to mind when you first asked the question was, if you're not in agreement about we should base our policy on evidence, if that isn't a fundamental shared starting point, then start with values. You know, find shared values, because, and that's often how we sell policy. I mean, you've talked about stories being everything, and stories are everything, and that's how all sorts of individuals and agencies propagate their agendas in society. So I would say meet the policy maker on shared values. And it might be, you know, if you're working in child health, it might be about, you know, there's a sort of universal right of a child to have an open future. You know, in Australia, we have particular values that we draw on all the time that resonate when we're speaking to people. So that would be I would say, the entry point, and you know, put evidence in your Trojan horse. And absolutely, people like to depend on evidence when they're selling policy. Yeah.
That is interesting, because I think having the value, it's almost like that should be the starting point. It probably should never be the evidence, should ever be the starting point. You really should have what it is that you're trying to achieve, and then look at what the evidence is saying. You know, rather than going in and saying, here, like what you did, here's the evidence, we need to change practice. It's not always one of the best strategies. It's having that shared value, or, you know, what it is, an understanding of what it is you're wanting to achieve, and then looking at what the evidence is saying.
Yeah. Let's do a poll, because I love audience polls. Put your hand up if you're confident you know the values of your leadership group.
It's always looking around at everybody. Everyone from JBI should have their hand up.
Okay. So it's a challenge, isn't it, actually, leaders to communicate their values and everyone else to listen and catch what those values are. Kate, I want to throw to you, because you spend a lot of time in coordination and management of significant issues. How do you start with considering values and shared values? Where does that come into the picture?
Yeah, I think that's really important, Craig. I mean, again, we've gone through some organisational change in the last 12 months. Our mission and our values has changed slightly as we've come together across one state. And I think the key with anything that we do, or anything we become involved in, is it aligned to the organisational values and priorities, and particularly for us, that's where we're going to get a lot of that leadership buy-in, if we can demonstrate that what we're doing is aligned to that.
Thank you. There's a question here about collaborative culture. Brian, much of your career has been about culture and collaboration. What are your thoughts on some low-hanging fruit on building healthy collaborative cultures?
70%, John Cotter found, he's a now emeritus professor at Harvard, found in 1996, 70% of change efforts fail flat out, 25% limp along, and only 5% succeed. And the most successful changes, they have got high levels of communication, engagement, talking to people, listening to fears, trying to understand, all of those bits. And 20% is Gantt chart, project planning, detail. Unfortunately, in most change efforts, it's the other way around. One of the upsides of COVID is actually there wasn't time for a lot of that stuff. It's like, okay, what do we know? What do we do? Who do we trust? Who are the trusted leaders who will get this over the line, because I can't? So I think it's about taking your ego out of the room and saying, who is the best person to do this? Yeah. And actually, it may be the cleaner, the ward clerk, who might have more in common with the patients than the terrifying nurse, allied, or the doctor. Yeah. So who are the people who can lead? And leadership isn't a job title, it's a set of behaviours. And echoing the earlier question about values, most people don't know what the values are because they're very rarely lived. And it's, you know, I've never come across a health organization that didn't say it was patient-centered anywhere on the planet. But if a place was patient-centered, why do we have visiting hours? So, you know, when it comes to the collaboration, the most untapped resource in healthcare are patients and their families. Why are they not part of the collaborative force for change?
Yeah. Thank you, Brian. For those of you that don't know, Carolyn Miller, Professor Carolyn Miller is one of the world's top public health researchers. We're blessed that she lives in Adelaide. I've just freaked you out, haven't I, by saying that? Because she lives her valley.
World's
so
a bit strong.
runs highly successful research, multiple research programs. Culture and value have to be intrinsic to the way your groups run. How do you, given we have some academic research staff here today, how do you build culture and collaboration for successful research?
Yeah, okay. I mean, I think, you know, I think culture and values is what you walk, not what you talk, definitely. And if you want to understand, you know, a policymaker or someone else's values, you learn that by watching what they do and what drives them. I mean, I suppose what I do in my group and working, so I'm with SAMRI and also with the School of Public Health at the University of Adelaide. And one of the things I suppose that I've really enjoyed shifting into SAMRI as an organisation is it's an environment where failure is absolutely, like endeavour is encouraged, and you want people, and this is something I suppose I encourage in my team too, I want everybody to be able to have the space to stretch and take risks and grow. And, you know, pursue something that's of interest to them. And then, but also I suppose there's an accountability, you know, there's a very real accountability in grant-funded research around funding cliffs. So, you know, none of us have secure jobs in grant-funded academia, that's for sure. Whereas in a kind of my previous life, which was in the NGO sector, there was a lot more security. But I suppose, you know, I don't want my staff worrying about that. That's what I think is my job to worry about. It's my job to take responsibility for people's job security and to give them an environment where they feel comfortable to, you know, take risks and grow and be as adventurous as they can. So that's what I encourage, I guess.
Terrific. Kylie, what are your thoughts about this? You run an implementation team.
Sort of. Maybe you can come back in a year and I can ask you that. I just think culture is important across all fields, not just like within teams, but like within your research. I was thinking about your research unit teams. So obviously you've got the people who, you know, who, like for us, who are summarising the evidence and what our culture is like. But then, you know, you're looking at the culture within implementations. For me, it's you need I guess, a positive culture across all the different teams. So you've got your academia team, but also your clinical team, and then it's getting a shared culture between the two. But I don't have any simple answers on how to create that. I think, you know, as long as you're communicating, checking in with people, taking critical feedback, like learning from your experiences, being out, like it's all of these things, being allowed to make mistakes. And feeling safe and secure, I think it'll all go. So pretty much what everyone else has said.
Well, I think that's a great illustration of lived culture, and that's exactly what we're looking for, I think, in this session. Adam, can I just ask, what are your closing thoughts on culture and collaboration and how you strengthen those things?
Yeah, I completely agree with everything that's been said around it. You know, there's the organizational culture, and then there are the local area culture bits. And, you know, I see very frequently all the time where one practice setting has a different culture. We have an organizational culture, but then one practice area setting has a slightly different culture than another practice setting and another one. And when we talk to our nursing staff who float between them, they know how they need to operate on one unit because the culture there is so different than another unit. So to be successful there, they have to, and it's okay. Like we're not trying to make everyone the same, but where culture intersects with collaboration all of the work we do as clinicians is collaborative. Like this is not an individual sport. We have to be collaborative. And so I think as an organization, the culture around collaboration is vital. And there has to be the venue, and there has to be the shared understanding that we need to collaborate with all of the stakeholders involved in clinical care.
Look, I believe we're out of time for this session, so I'm going to have to close it there. Would you please thank with me our guests who are here on stage today, and Adam and Kate from Brisbane and UCSF in California.